Well friends, today we'll be discussing gallbladder. We'll see investigative modalities to diagnose various gallbladder diseases and we'll see few congenital abnormalities of gallbladder. We'll see first functions of gallbladder. Gallbladder, it acts as a reservoir for bile. During fasting, resistance to sphincter of Oddi is high and hence bile excreted by liver is diverted to the gallbladder. After feeding, the resistance to flow through the sphincter of Oddi is reduced and gallbladder contracts and bile enters in the duodenum. These motor responses are affected by cholecystokinin. The second main function of gallbladder is concentration of bile by active absorption of water, sodium chloride and bicarbonate by the mucous membrane of gallbladder. The hepatic bile which enters the gallbladder becomes concentrated 5 to 10 times with corresponding increase in the proportion of bile salts, bile pigments, cholesterol and calcium. Gallbladder also serves to secrete mucus. Approximately 20 ml is produced per day. With total obstruction of cystic duct in a healthy gallbladder, mucocele develops because this mucus which is secreted gets accumulated in the gallbladder. Bile as it leaves the liver is composed of 97% of water, 1 to 2% of bile salts and 1% of pigments, cholesterol and fatty acids. Liver excretes approximately 40 ml per hour of bile, which is controlled mainly by cholecystokinin. Cholecystokinin is released from duodenal mucosa in response to food. With feeding, there is increased production of the bile because there will be increased secretion of the bile to the food. Now we will see investigations of biliary tract. First will be plain radiograph, which will be X-rays. X-rays will show radiopaque gallstones in 10% of patients. It will show the rare cases of calcification of gallbladder, so-called porcelain gallbladder, because it is important as pre-malignant condition and it is indication for cholecystectomy. Limey bile is a curiosity and is frequently related to multiple gallstones, which are small, but it is not a pre-malignant condition. So if you are asked which of the following is a pre-malignant condition, porcelain gallbladder or limey bile or any other combination of various conditions, it is porcelain gallbladder and it warrants cholecystectomy. Gas may be seen in the wall of gallbladder on plain X-ray, which will be due to emphysematous cholecystitis. So emphysematous cholecystitis is a condition where gas forming organisms, they have entered in the gallbladder wall and they will produce gas which will be seen on X-ray. So this is very condition of severe cholecystitis and this warrants urgent intervention in form of cholecystectomy. Gas in the biliary tree may be seen after endoscopic sphincterotomy or surgical anastomosis of biliary tree with gastroenteral tract. So after bilioenteric anastomosis, seen especially after choledochoduodenostomy or choledochojejunostomy, you can see the gas in the gallbladder or biliary tree. Oral cholecystography, it is done by iopanoic acid tablets taken in the night before and a control radiograph is taken before the tablets are given. And series of X-rays are taken on the following day with further films after fatty meal. The fatty meal stimulates gallbladder contraction and it reveals the adequacy of gallbladder function. Oral and intravenous cholecystography are of historical interest only as they are relatively inaccurate and have been discarded and replaced by more accurate imaging modalities. They can be used to diagnose diverticuli and polyps. Nowadays, ultrasonography, which is non-invasive, it is mainly the standard initial imaging technique. It will demonstrate biliary calculi, size of gallbladder wall, along with the thickness of gallbladder wall, if any rent in gallbladder wall, because if severe cholecystitis is there and associated gangrene of gallbladder has occurred, ultrasonography can pick up any rent in the gallbladder wall. It will also pick up if there is any collection in the gallbladder fossa between the liver and gallbladder, if there is formation of empyema in the gallbladder. Presence of inflammation around the gallbladder can very well be picked up on ultrasonography because there will be thickening of mesentery which will be forming a lump around the gallbladder. Ultrasonography can definitely tell you the size of common bile duct, presence of stones in the biliary tree. It may show a carcinoma of the pancreas occluding the common bile duct, leading to the dilatation of the common bile duct. Nowadays, endoscopic ultrasonography can also be used for visualization of the common bile duct. It allows visualization of the liver and biliary tree from within the stomach and duodenum. It is more sensitive for visualization of any common bile duct anomalies. It will provide accurate imaging of the common bile duct, and it is particularly useful in detecting stones within the bile duct along with choledochal lithiasis. In addition, it has been shown to be highly accurate in diagnosing and staging both pancreatic and periampullary cancers. Along with diagnostic purposes, US FNA, that is fine needle aspiration cytology, done through endoscopic guidance, can be helpful for assessing the malignant nature of the tumors of the lower end of CBD or periampullary growths. Endoscopic ultrasound, now forming the main modality, is the most sensitive tool to pick up any common bile duct calculi. So if you are asked question, which of the following has the highest sensitivity for picking up the stones in the common bile duct, you may be given options of endoscopic ultrasound, MRCP, then ERCP, because if it is a non-invasive tool, then amongst all these options, if they ask you specifically which of the following which is non-invasive and it is most sensitive, it is endoscopic ultrasound. But if you see invasive options, ERCP is the most sensitive tool to pick up any small stones. Technetium 99 scan can be done for gallbladder imaging. Technetium 99M, that is Technetium 99M TC, which is excreted in the bile, which is used to visualize biliary tree. In acute cholecystitis, the gallbladder is not seen. As the gallbladder, the cystic duct is occluded by acute inflammation, whenever it is dye excreted by the liver, it doesn't go in the gallbladder. So this indirectly means inflammation of gallbladder seen in cases of acute cholecystitis. The technique is used when biliary enteric anastomosis are functioning inadequately. So it will show the extent of obstruction at the anastomosis and indicate the delay in excretion. So this is also helpful in evaluation of the emptying of the biliary tree after a below enteric anastomosis has been done. So whenever patient has got recurrent cholangitis along with below enteric anastomosis, this is the method of choice of investigation to find out the obstruction, because other diagnostic imaging only will tell you the static functioning like MRCP, but dynamic images can be obtained through scintigraphy. Biliary scintigraphy may also be helpful in diagnosing bile leaks and iatrogenic biliary obstruction. Now we will see CT scan. This is imaging modality which will allow visualization of liver, bile ducts, gallbladder and pancreas. It is particularly helpful in detecting hepatic and pancreatic lesions and is the modality of choice in the staging of cancers of the liver, gallbladder, bile ducts and pancreas. So it is modality of choice in the staging of cancers of hepatobiliary tree. CT scan can also identify the extent of primary tumor and it will define its relationship to other organs and blood vessels. In addition, the presence of enlarged lymph nodes or metastatic disease can also be known on CT scan. For benign biliary disease, standard computerized tomography is not that useful an investigation. So, if you contemplate to evaluate benign biliary disease, CT scan may not give you adequate information. So, if you are asked which of the following diseases will be better evaluated by CT scan, and if the choice includes benign biliary diseases, then CT scan is not the main modality of investigation. Gallstones are not often visualized on CT scan and cholecystitis is underdiagnosed. CT scan may miss gallbladder gangrene. Nowadays, MRI can be used to evaluate hepatobiliary or gallbladder, standard technique for investigation of biliary tree. It has become a method of choice for investigating biliary tree non-invasively. Contrast is not necessary because water in the biliary tree will itself form a contrast. Especially T2 weighted images are very helpful. Using appropriate techniques, excellent images can be obtained of the biliary tree that demonstrate ductal obstruction, strictures or other intraductal abnormalities. It is sensitive and specific to the diagnosis of bile duct stones. They will form a filling defect on the MRCP. But mind well, as I told you earlier, the most sensitive non-invasive tool for diagnosing bile duct stones is the endoscopic ultrasound. ERCP has becoming the diagnostic and also therapeutic modality for evaluation of the gallbladder tree. The ampoule of water is cannulated with the aid of fiber optic duodenoscope, which is side viewing duodenoscope. The bile ducts are visualized. It is especially useful in determining the cause and level of obstruction. Bile which is obtained after cannulation of the biliary tree can be sent for cytological or microbiological test. Brushings can be taken from stricture for cytological studies. So, apart from EUS, FNA that we have discussed earlier, cytology can be obtained through ERCP through brushing of the obstructive stenotic lesion. Therapeutic interventions such as stone removal or stent placement to relieve the obstruction can also be performed through ERCP. Thus, ERCP has evolved into mainly therapeutic rather than a diagnostic tool. So it is said, if you want to do some therapeutic intervention, then only do ERCP. Otherwise, MRCP is sufficient to diagnose various lesions. Percutaneous transhepatic cholangiography, which is also short term as PTC, can be used for various obstructive lesions of biliary tree. This is an invasive technique. It will demonstrate areas of stricture or obstruction in the placement of catheter into bile duct to provide external biliary drainage or insertion of indwelling stains. So, PTC will evaluate various levels of stricture which are located high in the biliary tree, or catheter can be placed across strictures with the use of PTC. With these catheters, external drainage of bile can also be done, and afterwards for high stenotic lesions, these external biliary drainage catheters can be internalized over series of guide wires after dilatation of the stricture. Operative biliary endoscopy, which is also called as choledocoscopy, can be done to remove residual stones. This technique is invaluable in management of difficult stone diseases. So, after you do laparoscopic or open cholecystectomy along with biliary tree exploration, that is common bile duct exploration, and if the T tube is left and if you find some stones which are left incidentally in the biliary tree, after the removal of the T tube, the tract which is formed can be dilated over serial dilators, and choledocoscope can be inserted to retrieve the stones which are difficult in location and which cannot be removed by the ERCP or peroperative methods. Fine flexible choledocoscope can be passed into intrahepatic biliary tree in order to diagnose strictures or to take biopsies or to remove stones. If a malignant stricture at the level of confluence is detected, say in confluence of right and left hepatic ducts, or which is higher than them, PTC is preferred to an ERCP. So if you are asked question, which of the following investigation will be helpful in cases of hilar strictures or which is classically called as Klatskin tumor, then if you are given option ERCP, MRCP, PTC, then it is PTC that is form the preference over the ERCP, because it is high stricture. PTC will form preference over the ERCP. Peroperative cholangiography can be done during open or laparoscopic cholecystectomy. It is done by a catheter which can be placed in a cystic duct and contrast is injected directly into biliary tree. The technique defines the anatomy and is mainly used to exclude the presence of stones within bile ducts. Now we will see various congenital anomalies. Congenital anomalies of gallbladder, which are more common, they can be absence of gallbladder, they can be Phrygian cap, which is just a normal deviation of development of gallbladder and it has got no other significance, just like it looks like a cap. There can be floating gallbladder when gallbladder has excessive long mesentery. There can be double gallbladder or cystic duct can be absent. Sometimes the cystic duct can be inserted very low on the common hepatic duct when it runs very much parallel to the common hepatic duct. There can be accessory cholecystohepatic duct. This has got a significance in a sense. During cholecystectomy, if you forget to identify this duct, then this can lead to the bile leak in spite of doing good cholecystectomy. So this duct should be looked for dissection of the Callo's triangle, or after dissection of Callo's triangle, when you take off the gallbladder from hepatic bed, this duct should be looked for. Now we will see extrahepatic biliary atresia. So by atresia it means the absence or stenosing of the any tubular lesions. So extrahepatic bile ducts are progressively destroyed by an inflammatory process which starts around the time of birth. The etiology is unclear. Intrahepatic changes also occur and eventually it may result in biliary cirrhosis and portal hypertension. Untreated, if this condition is untreated, death can occur from the consequence of liver failure. So generally it occurs within the ages of 3 years once it is diagnosed. So children which are diagnosed, they don't survive after 3 years if they are not treated in time. The inflammatory destruction of the bile ducts has been classified in 3 main types. So if these were to biliary tree, these are common hepatic ducts. These are right and left hepatic ducts. This is common hepatic duct, this is cystic duct, gallbladder, and this is common bile duct. So whenever there is type 1 disease, the atresia is mainly limited to the common bile duct. The type 2 in which the atresia is limited to the common hepatic duct. In type 3, there will be atresia of right or left hepatic ducts. So in these cases, associated congenital anomalies, they are very much common in form of cardiac lesions, polycythemia, situs inversus, absent vena cava, and preduodenal portal vein. So kindly definitely make note of this. So if you are asked question, which of the following conditions are not associated with extrahepatic biliary atresia, then you should be able to answer this question. Patients are jaundiced at the birth, which deepens progressively. The mechanism may be very much little bile stain and urine is very dark. Prolonged cystinuria will give rise to the osteomalacia, which is also called as biliary rickets. So biliary rickets is seen in extrahepatic biliary atresia. Clubbing along with skin xanthomas, probably related to a raised serum cholesterol, may be present. So this condition should be diagnosed from a jaundice seen in neonate, which may be after any cholestatic picture, especially seen after alpha-1 antitrypsin deficiency, cholestasis associated with intravenous feeding and choledochal cyst, or it can be inspissated bile syndrome. Neonatal hepatitis is the most difficult to differentiate. Both extrahepatic biliary atresia and neonatal hepatitis are associated with giant cell transformation of hepatocytes. So it is difficult to differentiate between two. Liver biopsy and radionuclide excision scans are essential to differentiate between these two. Now we will see treatment. The type 1 lesions, direct Roux-en-Y hepatocogenostomy can be done. So for type 1 lesions where this stenosing or atresia of this type of CBD, this common hepatic duct can be Roux-en-Y anastomosed with the small bowel. In type 2 and type 3, this is treated by Kasai procedure in which radical excision of all bile duct tissues up to liver capsule is performed. So if there is further obstruction or further atresia of biliary tree, then the Kasai procedure is done. So if this is liver and there is all atresia of all this tree, then Kasai procedure is done, which is also called as portoenterostomy. So all biliary tree, all this across liver capsule are taken out and directly bowel is anastomosis to the liver capsule. So Roux-en-Y loop of jejunum is anastomosed to the exposed area of liver capsule above the bifurcation of portal vein, creating portoenterostomy. The chances of achieving effective bile drainage after portoenterostomy are maximal when operation is performed before the age of 8 weeks. So if the patient presents prior to 8 weeks, it has got excellent prognosis. Post-operative complications include bacterial cholangitis, progressive hepatic fibrosis. Liver transplantation can also be done. So friends, after seeing atresia, we will see one more interesting congenital anomaly, which is choledochal cyst. It is an isolated or combined congenital dilatation of extrahepatic or intrahepatic biliary tree. It is common in Asians and females. It is more commonly seen in females. It is common 4 times common in females as compared to males. It is anomalous junction of the pancreaticobiliary junction, which are frequently observed, but role in the pathogenesis of this condition is unclear. Type 1 cysts are the most common and account for the 75% of the patients. So we'll see the classification in detail. We'll see now the various classifications of this system. So biliary tree is depicted by this. If there is type 1, so dilatation of extrahepatic biliary tree in type 1, which will be cystic. So this area is involved, which will be dilatation will be cystic, focal or fusiform. In type 2, there will be saccular dilatation of the extrahepatic biliary tree. So there will be saccular outpouching from the extrahepatic biliary tree. In type 3, there will be duodenostele. So this is the common bile duct. When it opens in the duodenum, the type 3 will be cystic nature in the duodenum, which is called as choledochal or at the entry of the ampulla of water. Type 4a is dilatation of intrahepatic and extrahepatic biliary tree. So intrahepatic always extrahepatic dilatation are seen in type 4a. Type 4b combines multiple extrahepatic dilatations. So multiple extrahepatic dilatations are seen in type 4b. Whereas type 5 will be dilatation of intrahepatic ducts. So in type 5 there will be dilatation of intrahepatic ducts mainly. So if you are asked various questions, in which of the following there will be dilatation of only extrahepatic which are multiple. So it is only type 4b and type 4a. So you should undergo this classification very carefully, because there can be permutation and combinations of questions can be asked on this. So this interesting condition has basically theoretized in three ways. There can be anomalous pancreaticobiliary junction. So this pancreaticobiliary junction can be anomalous, or there can be abnormal canalization of bile duct, or there can be abnormalities of autonomic innervations of extrahepatic biliary tree leading to the dilatation of this system. Histologically, there are two main types, the glandular and fibrotic. Glandular cavities in the mucosal layer with inflammatory cell infiltrate, and fibrotic has thickened bile duct which is well developed collagen fibers with less of inflammation. Clinically, it is more common in females than in males. So if you say 100 cases, then there will be 4 times female and 1 times male. So typically choledochal cysts are present in early infancy, but cases can also be present in adulthood. Patient will have attacks of jaundice, upper abdomen pain and pyrexia, and upper abdomen mass along with nausea and vomiting. So these three main features like attacks of jaundice, upper abdominal pain and pyrexia, and upper abdominal mass are the main significant features of choledochal cyst. MRCP is the best non-invasive investigation. Ultrasonography can also be done. CT scan will help to rule out any further abnormalities. Barium will show displacement of the duodenum. Radionuclide imaging will show filling defect in the liver, or there will be dye accumulation in the cyst. ERCP can also be done to find out any malignancy or take the breast cytology. Complications of choledochal cyst include ascending cholangitis, recurrent cholangitis, biliary cirrhosis which is rare, pancreatitis, gallstone formation, diffuse peritonitis if the cyst get rupture, malignancy, portal vein thrombosis along with portal hypertension. If there is repeated inflammatory attacks, portal vein which is adjoining can undergo inflammatory thrombosis leading to the portal hypertension. How do you treat this condition? The cysts are excised with reconstruction Roux-en-Y hepatogenostomy or choledocogenostomy is a treatment of choice for all choledochal cysts except type 3 and intrahepatic cyst of type 4 and type 5 Carol's disease. So cyst excision, you excise the cyst. You do not do cyst enteric anastomosis. The cysts are excised and below enteric anastomosis is done above the normal biliary tree in these cases. Especially in type 3 which is choledococele, there can be sphincterotomy or sphincteroplasty can be done. For intrahepatic cysts which are type 4 and type 5, if the intrahepatic cysts which are localized, then lobe is resected. So intrahepatic cysts which are localized, then that lobe is resected. If the intrahepatic cysts are diffuse, then only effective treatment is liver transplantation. So if all the cysts are diffuse, then only liver transplantation is the only effective and curative treatment. Choledochal cyst is a risk factor for the following cancer: biliary tree, which is the most common, gallbladder, pancreas, liver and duodenum. So if you are asked various conditions which can be risk factor for the malignancy, choledochal cyst should be kept in mind because there can be various questions on this. Cystoenteric anastomosis is not done as it will leave cyst wall intact with the development of cholangitis and rarely malignancy. So when you want to treat these conditions, the gallbladder along with the abnormal cysts are taken down and below enteric anastomosis is done. So friends, we saw various modalities of evaluation of gallbladder. and various congenital abnormalities along with choledochal cyst